Hello, everyone. To welcome you all to this webinar, which is on improving rural health information systems for health equity. Next slide, please. So my name is Theodora Koller, and I'm Senior Technical Officer for Health Equity in the Gender Equity and Human Rights team here in WHO headquarters. And I'm very pleased to be with you all today for this edition of the Rural Health Equity webinar series. This is a webinar series that is being convened under the umbrella of World Health Day 2021 on health equity, and it's done in collaboration with Wonca, so the World Organization of Family Doctors, as well as OECD and also agencies from the UN subgroup under the inequalities tasks team, the subgroup that specifically looks at rural inequalities. Next slide, please. So today we are joined by Stavdal, who's the president of Wonca, as well as Ahmadreza Hosseinpoor, who will talk about the Health Equity Assessment Toolkit, Karin Stenberg and Prashant Hedao, who will speak about ACCESSMOD, and Betty Ann Bryce, who's coming from OECD, as well as Wanjala Nafula from the Wonca Rural Seeds. And finally, we'll have closing by Bruce Chatter from the Wonca Working Party on Rural Practice. Next slide. So I just want to kick off by saying a few words about the focus of today's webinar, which is on strengthening rural health information systems. So we know that globally, 4 out of 5 people experiencing extreme poverty live in rural areas. And to ensure that we meet their health needs, we need to take a progressive universalism approach. That means that we need to reflect this approach also in the way that we gather data. So across all data sources, we need to make sure that we are capturing information that it highlights inequalities that can be experienced by rural populations, as well as subpopulations within rural areas. So this means looking at data disaggregation capacity with regards to population-based surveys and census, also looking at equity-oriented approaches for health facility and community information systems, silver registration and vital statistics, surveillance, health systems monitoring sources, and other non-health sector sources. Next slide, please. So just a few words on civil registration and vital statistics, as this is really central. Here we know that there are persisting inequalities that exist in birth certificate coverage in most low and middle income countries, as you see by the data featured here, with rural areas lagging behind. And weak civil registration and vital statistics systems lead rural and poor children to be systematically excluded from the benefits tied to a birth certificate. And they also prevent these children from being counted in national health data. Next slide. Now just coming here to work that has recently been published by WHO for its report on tracking universal health coverage. And this refers also back to my previous slide when I was talking about population-based surveys. Here in this recently released report, that includes data on the RMNCH Composite Coverage Index, so the Reproductive Maternal Neonatal Child Health Composite Coverage Index. And we see with this figure that globally, in the 79 countries that captured data by place of residence, that rural populations are lagging behind in terms of the composite coverage index. And then when we break this down by country income group, you see again with the blue dots here, residents along the bottom, that in low-income countries, there is a significant gap between urban and rural for the composite coverage index. Next slide. And we also know from the recently launched report on state of inequality, HIV, TB, and malaria, that there are persisting inequalities between rural and urban populations, as well as between income or quintiles. So just to highlight that these types of data sources are very important, as I showed with the previous slide and this one, for highlighting the needs of the rural poor. And we need to increasingly look at how we can capture such types of data. Next slide. Finally, a word on social determinants of health in rural areas. We, in addition, need to capture data from other sectoral domains that help us understand the factors that are contributing to ill health related to the social and environmental determinants. And here, I just wanted to highlight some data from our colleagues from UNESCO on education levels in rural areas. So their 2020 report on inequalities in education has highlighted that for every 100 urban residents that complete secondary school, only 23 rural residents do so, and that in at least 20 countries, less than 1% of poor rural young women completed upper secondary school. So our data systems also need to capture this type of information to understand the factors influencing health. Next slide, please. So just to recap, it's really important for us to consider how these different data sources can take into account capturing data on inequalities and monitoring these and having a health equity focus. I'd like to now, with this next slide, please, hand over to Anna Stavdal, who's the newly elected president of Wonca, to say a few opening words. Thank you. Over to you, Anna.
Thank you so much. It's a pleasure as newly inaugurated president of Wonca to be given this opportunity to greet organizers and participants alike on behalf of our huge global network of family doctors. Big thank you to WHO and the Wonca Working Party on Rural Medicine for co-organizing this webinar. It goes without saying, continuous dialogue between those who are working out policies and those who are implementing them is a requirement for improving impact of health policies on health outcomes. So we should aim at establishing these circular dialogues, loops, to make sure we keep going on the right and the same track. So in light of that, it's a delight to see this webinar series taking place, where the policy dialogue is brought out also to the public. Let me now share a couple of slides with you to guide me when I will present a few points about Wonca. Who are we? We are more than 500,000 members. The majority arrives through one of the 132 member organizations in 110 countries, grouped into 7 regions, well known to the WHO. And you see the distribution, at least we can see almost the full slide here, the distribution of the member organizations in the regions. The professional development activities take place in the special interest groups and the working parties. And you see them listed here. The special interest groups focus mostly on clinical fields, whereas the working parties focus on overarching topics. So you can see like education, environment, ethical issues, and rural practice. For the global organization, we need to focus on what unites us. And at the same time, it is vital to recognize how family medicine looks different, is manned differently, and requires different training schemes due to the context. The Rural Medicine Working Party contributes exactly to that and enriches our internal discussions when we are looking for synergies in our professional development activities, and not least in our advocacy. I'm from Norway, a country with long traditions in primary care and a very long country geographically. a small population spread over this a long land. And the discussion on equity in healthcare is always a part of national health policy dialogues. So I'm used to that. But I think this dialogue also is relevant for all countries, regardless of geography, regardless of geographical distance being the only variable we're looking at when we are discussing remote or rural and urban medicine. I'm looking forward to develop this discussion and add nuances to this discussion, which I'm sure this forum is very competent to do, and to continue that discussion and develop that with you in the time to come. Let this be the few words I want to say now at the start of the webinar. I'm looking forward to hear and maybe take part in the deliberations, and wish you good luck on the webinar. Thank you very much.
Thank you so much, Anna. It's a pleasure to have you with us and to be partnering for this series with Wonca. I would like to now please hand over to Ahmadreza Hosseinpoor, who's a medical doctor and an epidemiologist working at the World Health Organization in Geneva, where he leads the work on health inequality monitoring. He has conceptualized and coordinated the development of resources and tools in this area, and is lead author of a number of peer-reviewed articles quantifying inequalities in health. He will briefly describe the WHO Health Equity Assessment Toolkit and will demonstrate its application in assessing rural-urban inequalities in health using country examples. Ahmad, over to you. Thank you so much for being with us.
Thanks very much, Theodora. Hello, everyone. It's a great pleasure to be here and to present to you the WHO work on health inequality monitoring and to show that how it could be applied to urban-rural monitoring part. So as all we know, equity is at the heart of WHO's work. Serve the vulnerable is one of the 3 pillars of WHO General Program of Work, the 13th Program of Work. And also equity is at the center of Sustainable Development Agenda with the aspiration of no one leave behind. One of the targets, SDG, target 17.18 actually calls for enhancing the availability of disaggregated data that are high quality, timely. So recognizing the importance of inequality monitoring, WHO has developed a package of tools and resources to build the capacities in countries for monitoring health inequality, and that includes several tools, including data sets of disaggregated data, which includes Health Equity Monitor, one of the largest global database of disaggregated health data that I'm going to explain a bit later. We also have developed global thematic reports on a state of inequality as well as some national inequality reports. We do produce handbooks, manuals, e-learnings, again, on this topic. And one of the tools, it's the software application that I'm going to explain to you just in a minute. That's another way to build the capacity. And all of these tools we use to build the capacities in the countries through training workshops that we organized for the countries and WHO regions. So, Health Equity Assessment Toolkit, what is it? That's a software application that allows us to assess within country health inequalities. So it has 2 editions, HEAT and HEAT Plus. HEAT is the built-in database edition that comes with WHO Health Equity Monitor database. HEAT Plus, it's the upload database edition, doesn't have any database inside built in, but it allows users to upload their own data set to the tool for assessing health inequality. Both editions are available online and also as a standalone version, can be used on the desktop. And we have them in 4 languages: English, Spanish, Portuguese, and French. And all of them come with a range of documents and supporting materials. So, Health Equity Assessment Toolkit. Before going to the toolkit itself, just explaining what the database is inside. As I said, that's the WHO Health Equity Monitor database that includes over 30 health indicators, mainly from the domain of reproductive, maternal, and child health, disaggregated by several dimensions of inequality: age, sex, economic status, place of residence, education, and geography, subnational regions. And it's based on the reanalysis of more than 450 international household surveys, mainly DHS, demographic and health surveys, mixed multiple indicator cluster surveys, and RHS reproductive health surveys that are conducted in about 115 countries over the past 3 decades. So let me now move to the actual toolkit itself. Just sharing the tool. So that's the home page of the tool. And you see here, the whole toolkit is around 2 areas: explore inequality and compare inequality. Explore inequality allows the users to see the status of inequality in one country of interest, latest situation, and also change over time. Compare inequality allows us to compare the within country inequality of our country of interest with other countries from same region or different regions or different income groups. So let's have a quick look at explore inequality. Has 2 parts: disaggregated data and summary measure. So I start with disaggregated data. And here we can see several tabs, several views to look at the data on the right. And on the left, we can see our selection panel. And in that selection panel, we can choose our country of interest from the list, data sources, the year of the data, different health indicators can be selected here, and inequality dimensions, as I mentioned before. So here we're just looking at, by default, skilled birth attendance by place of residence. So in this visual, if we want to have a quick look at it, we can see the births attended by skilled health personnel disaggregated by place of residence, urban, rural, over time, for which we had data in Indonesia. So we can see the list of the surveys, DHS, and it's started on the y-axis, the years 1994 goes to 2017. And on the x-axis, we can see the coverage, the percentage of births attended by skilled health personnel ranging from 0 to 100%. And we can see here in 1994, there was a large gap between rural and urban area in a skilled birth attendance coverage. As you can see here, about 27% in rural area, like 1 out of 4 births only attended by skilled personnel in rural area, while the coverage was 80%. The good news is that now over time, as we can see, the gap decreased hugely. So we can see that actually the gap in 2017 between urban and rural area is quite small. So that's about less than 10 percentage points. And that's thanks to faster improvement of coverage of skilled birth attendance in the rural areas comparing to urban areas. That's actually what expect to happen with many interventions that are traditionally have lower coverage in the poorer group, less educated and rural area to close the gap. So that's, we can see clearly good improvement in terms of closing the gap, at the same time improving national average. We can look at other indicators as well. So I can add, for example, an indicator of reproductive health. Let's say, I'm just typing it, family planning, demand for family planning satisfied. So I can also use an indicator for child intervention, measles immunization coverage. And we can look at the pattern in those indicators also. So we have maternal, reproductive, and child health interventions. In demand for family planning, we can see actually the inequality was quite small. It was really small in 1994. It got sort of to no inequality. And in 2017, it's still very small, but it reversed. So actually, we can see rural area has a bit higher coverage of demand for family planning comparing to rural area. In measles immunization coverage, the gap was large, relatively large. In 1994, it wasn't as large as the skilled birth attendance, but the gap has started to decrease over time, especially when we look at it in 2017. We really have very small gap between rural and urban areas. So that's the way that we can easily compare the urban-rural inequality in different health interventions and see which program is more equity-oriented and how the improvement in terms of reducing inequality is being done over time using this application. We can also look at summary measures of inequality. So what are they? As we can see here, disaggregated data is quite helpful because we can see the pattern of inequality, how is it changed, what is the situation in subgroup. But if we want to quantify the magnitude of inequality and just say it with one number, which helps us to talk about change of inequality over time or comparing it across countries, then we use a summary measure. As it names, it summarizes the results of inequality, like the difference between poorest and richest, as it's mentioned here. So we all know about some of the summary measures of inequality, the simple ones. Here, example here, we're just showing difference between urban and rural area. The toolkit actually calculates many summary measures of inequality that applies to each measure, each dimension of inequality. So if we, for example, pick up instead of urban-rural, wealth quintile, or subnational region, or education, we can see the relevant summary measures of inequality that applies to those dimensions of inequality. So here, quickly again, to get a sense that what we are talking about. Again, in this visual, we can see all three measures, all three health indicators in one visual, and looking at the difference, urban-rural difference in each of those summary, each of those indicators over time. And again, the messaging is the same. So we can see for skilled birth attendance, there was large inequality, over 50 percentage point difference between urban and rural in 1994, which decreased massively and then continued to decrease. Yet in 2017, this indicator still has the largest urban-rural inequality comparing to demand for family planning and measles. And as we can see for demand for family planning, the inequality was quite low and it got 0, and then it reversed a bit. One thing about the tool is that basically we can modify, if we go to options, the way we want to see everything. So we can actually put numbers here and modify the view so we can get more information about that. We can provide the title, change the title, and do all sorts of modification that we want to put here. For example, for access, we can put year and it appears here. And then we can download the visual as JPEG or PDF. So we can put the image in our reports, Word reports, or we can get the data fully. So we can download the data in. So that's another thing that we can look at with the tool. I'm just going to escape to go to the compare inequality, but that's also another option that we can see the situation in the countries, comparing the situation in Indonesia, for example, with other countries, with highlighting, for example, what countries we would like to get. I mean, just to show you quickly how it is, we can pick up countries from other regions and then see what are the situations in other countries and then compare it. So for example, in Indonesia, I can see urban-rural inequality is about 10 percentage points, but then there are countries like Timor-Leste that inequality, urban-rural inequality is much larger than Indonesia. But on the other hand, there are countries like Thailand and Maldives that there is no inequality, urban-rural inequality. So that's the way the tool could help us to really assess the situation of inequality and see where we are. So we have the HEAT Plus, the uploaded database edition of the tool. And with HEAT Plus, that allows us to look at inequality at any level, global, regional, national, subnational level. And we can import, upload any data source. It could be coming from a survey, from admin data, from census. So there is no limitation in terms of type of the data source. Also, broadly speaking, we can use any indicator, health or not health related, because that's the software. So it doesn't really recognize the indicator is health or not. So broadly speaking, we can disaggregate, use the toolkit for showing and analyzing disaggregation of any indicator by any dimensions of inequality. So of course, our interest here is urban-rural, but one application of that is that several times we want to have double disaggregation of data. So doing some further disaggregation within rural areas by wealth quintile, for example, and compare it in urban area by wealth quintile, and that's possible to do that double disaggregation as well. And then that's the resources, some of the references that are available here for use. And for HEAT Plus, we so far developed a data repository of having different type of data sources on different topics. So when you go to the Health Equity Monitor, you can see that. And then just one quick point that I may want actually to show you is that on the website, then where we can see the data. So that's the data that you can see on our website, Health Equity Assessment, and you can see the online version and basically the online version for HEAT and HEAT Plus and desktop version for HEAT and HEAT Plus that you can download. And it comes with several supporting materials, including manual, technical notes, and we have training videos that actually walk you through each parts of the toolkit and to show you how to use the tool for the analysis and reporting. So thanks so much. I stop here.
Ahmad, thank you so much for sharing these really brilliant resources. And I really would like to encourage everyone in this webinar and then also later seeing the recording to check out HEAT and the resources that Ahmad has shared. I think they will be very valuable in your efforts to improve rural health equity. So I would like to now hand over to our next set of presenters and welcome our colleagues who are working specifically on ACCESSMOD. So I'd like to welcome Karin Stenberg. She's a health economist working for WHO since 2004. Her work centers on analytical tools and models that countries can use to assess the investments needed to advance universal health coverage and bring essential services to people in need. And she will be presenting today with Prashant Hedao, who is a consultant with the newly established Geographic Information Systems Center for Health at WHO headquarters. He's a specialist supporting various projects at WHO, such as the Global Health Facilities Database, and is the team lead for the snakebite envenoming project. And jointly, Karin and Prashant will provide an overview of the ACCESSMOD tool. This is a tool that can be used to analyze existing health facilities and systems and to analyze how timely access to healthcare might differ for the population within a country. So over to you, Karin and Prashant, and thank you so much for being with us.
Thank you so much, Theodora, and good morning, good afternoon to all participants. It's an honor to be here presenting in this seminar on these very important topics related to how to make services more equitable. And without further ado, perhaps we can advance to the next slide. I will start by giving an overview of the ACCESSMOD tool and how this relates to universal health coverage. So universal health coverage is really about access to a guaranteed set of health services for everyone. And it's one of the targets for the Sustainable Development Goals, as I'm sure everyone is aware, where the target is defined as including financial risk protection, access to quality essential health services, and having access to safe, effective, quality and affordable essential medicines and vaccines for all. So really providing health services to all, a guaranteed set of health services to all. But in doing so, many countries are advancing on defining the kind of services they would like to provide and at what cost. But of course, if we want to make these services available to everyone, it's very important to look at a number of aspects, such as financial access, geographic access, ensuring that services are high quality and that they're safe and effective. So ACCESSMOD, if you go to the next slide, next please, yes. ACCESSMOD is really about looking at whether health systems are set up to facilitate geographic access. I think it's just, if you just click, there's a little animation there. Oh, sorry, go back. Yeah, thanks. So we just heard Ahmed tell us about the inequities that we have in access to services across countries and the data that we have at various levels. What are the reasons for these inequities? And often one of the reasons is simply geographic access. Health facilities are not located in locations where the population can access them. And they need to travel through various types of land cover, vegetation, jungle, rivers. There might not be paved roads. Basically, it's really, there's a transportation issue. There's travel that needs to happen in order to even come to the health facility. So ACCESSMOD is really a tool that's been set up, and it looks at how can the population travel to health facilities. It takes into account the distance, of course, but also the quality of the road network and how the population could travel on this network, what's the speed at which the population could travel, the means of transportation available, the type of vegetation or land cover that you would have to go through from your village to even get to the road, and different barriers like mountains or rivers or lakes that you need to travel around or cross. So it's really about looking at really practical issues of how to get from your house to the health services. Next slide, please. It's a software tool that you can use to look at these issues, and to date, it's been applied in over 15 countries. We've had different versions of the tool, and now we're at version 5. which is an open source tool. And probably version 6 that we're working on will also entail a shift to an online platform, which will make it even easier, where you can use a web browser to access the tool and run your analysis. We see in this photo here, it's from a workshop we did a few years ago in Burkina Faso, where we looked at the issue that we just talked about, that Ahmed presented, which was access to skilled care at birth. And we sat down with the Ministry of Health and various stakeholders to look at how can women right now in Burkina Faso access skilled care at birth. And we ran a geographic analysis on this. Next slide, please. So here again, we have animation. Yeah, if you just click through, there's 5 types of analysis that we can use the tool for. So the first one is accessibility analysis. It's really just looking at where is the population located, where are the health facilities located, and then the other data around the road network, the speed, whether there's a rainy season, dry season. And we use all these data to calculate travel time, and we can see it illustrated on maps. The second type of analysis is geographic analysis, where we can also look at the coverage capacity of each health facility. So how many nurses do we have in each single health facility? And what's their capacity to deal with patients living in the specific geographic area around that facility? And again, we can draw maps to look at how well are these facilities equipped to handle the need of the population. The third type is referral analysis, is to calculate the travel time and the distance between, for example, a primary care facility and a hospital. If you need to refer someone, for example, if there's a need for emergency care, what's the travel time to actually get to the more advanced hospital facility? The fourth type of analysis, zonal statistics, it's really to look at the subnational level, what's the percentage of population that can access services. And finally, we have scaling up analysis, where you can say, I've looked at the situation in my country. I can see there's a certain area where I need to improve access and equity. Where should I place the new health facility? What's the optimum location to ensure that population can access it in the shortest time available? Next slide, please. So here's just one example, as I mentioned, from Burkina Faso, where we mapped what's the travel time to the nearest health facility for basic emergency obstetric care. And generally, we used the benchmark. We said women who are in labor should be able to reach basic emergency obstetric care within 2 hours of travel time. And here you can see on the map, everything that's colored in green, the population living there can access care within 2 hours. For everyone living in yellow or orange or red areas, they need more than 2 hours of travel time. So only about 61% of women could actually reach care within 2 hours. So now, as a health planner, this is really important information for me, not just to see equalities or inequities, but also to ask myself, where should I build new facilities in my country? Next slide, please. Another question is, where should I push my system resources? Where should I push my health workers? Where should I push my equipment? Where should I push my financing? So here's another example. We worked with Malawi. So on the left-hand side, you can see a map of Malawi. Again, everything that's green here, we used a cutoff of 90 minutes. Here we used a cutoff of what percentage of women can access care within 2 hours. And again, it's within 2 hours. So where it's green, in those areas, over 90% of women can access care within 2 hours. In the yellow areas, it's between 75% and 90. 75%, maybe you can say it's still not so bad. But what happens when they get to the facility? Are there enough health personnel there? And on the right-hand side map, you can see, again, there are inequities in terms of whether they are appropriately staffed and equipped. So it's again a question for a health planner if I should push for having more nurses or more equipment, better equipment, in which regions, in which districts should I place these resources? So this is where the tool can be really helpful to inform your strategic thinking. Next slide, please. Okay, so that with that overview and some examples from maternal health, I'll be handing over to Prashant to tell us more about ongoing work on snake bites. Thank you.
Prashant, we can't hear you.
Okay, my apologies.
Oh,
can you hear
ahead.
me now? Yeah,
Yes.
Sorry about this.
Yes.
Yeah, so thanks, Karin, and thanks for giving me this opportunity to speak at this webinar. Snake bite is a very serious problem around the world and very highly underreported, and it affects largely people living in rural areas, people who work in the fields, people who live in the on the fringe of the forested areas, and you know, it's largely a thing that happens in the rural area. And as I said, there are it is highly underreported, and so data is very sparse on the snake bite incidences and how many people die. But it is estimated that about 146.7 million people across the globe live within the range of one or more venomous snakes and without adequate healthcare provision. And looking at the seriousness, it was added as a neglected tropical disease in 2017, and it can be treated, and but only thing is lack of access to antivenom treatments and facilities and expertise for treating it. So we created a story map, and that story map link is there at the bottom, and you can get all the information about seriousness of this. So this project that we are doing, next slide, please. So this project that we are working on is actually a project for the NTD department within WHO, and David Williams, Raphael, and Mike Turner they are here in this as participants, and they are the main lead from on this project from the NTD side, and I'm working from and few of us are working on this from the GIS center side, mapping the. So in the phase one, what we did was we created a snakebite data platform where we created the snake range distribution areas for all the venomous snakes, about 292 of them, and we disseminate information about these snakes, their range, what is the antivenom, how much population gets affected by this. Next slide, please. So this is what the overview platform looks like. You can scroll through the snakes. There are about over 900 photographs are there on this in case you want to find out which snake bit you or what the snakes looks like. And you can select them by the scientific name, common name, or you can just select a country and it will show all the snakes from that country. And it also tells you the common name, the category, risk category, and also how many people and how many countries that snake is present, and the population possibly affected by that. And as you scroll down, you can also see the antivenoms of that and the publications and scientific publications that are published on that particular snake. And it also shows a map. Next slide, please. And you can also download a map for each snake species that looks something like this, that gives all the information that's available for that particular snake. Next slide, please. So that was the phase one part, and we launched the platform on September 15th. Our chief scientist was the main chief guest who launched this platform. And in the phase two, we are actually looking at access to health facilities, the two boxes that are highlighted, which is access to health facilities for the vulnerable population. And the second one is how we get to the antivenom stockpiles and equipment and all the supplies that are needed to get to the logistics planning of the stockpiling and other facilities that are needed in the snakebite training center, snakebite treatment centers. Sorry. So next slide, please. Yeah, so this is just an example. This is the ongoing work. And what we have here is a country, Eswatini, around in southern part of Africa, where we are looking at how many people would have access to a hospital that treats snake bite. So this is not really a final model or something. This is just testing of the model, that how we can do this. So a lot more work needs to be done, and this project will be actually ongoing until end of the year. The idea is to find out where we need these snake bite treatment centers, and that will be determined based on where are the high densities of venomous snakes, the land use of that area, what people do in that area, and the population, of course, the population numbers that are there. So that will determine where we need the snake bite centers. We are also looking at how, as I mentioned earlier, how we can get the antivenoms at those snake bite treatment centers, and that will also be used for logistics of getting those snake bite centers, and also the referral facilities. If somebody goes to a snake bite center and it's very serious case, how do they refer to the next center, and how the person gets there. So this is ongoing work, and it will go on until, as I said, until end of this year, and 2022, and we hope to cover 14 countries in Africa, 7 in East Africa and 7 in West Africa. Next slide, please. That's probably the last slide. Yeah. So these are some URLs that we have here, and ACCESSMOD URL, and also the story map that gives you all the information about snakebite and its seriousness. And the data platform is who.int/snakebite-data-platform. Thank you.
Thank you so much, Karin and Prashant. That was really fascinating to see your work on ACCESSMOD and how useful it can be, in particular for health policymakers and planners, and provide really insightful information on decreasing spatial inequalities in terms of equitable access to services. And as someone who's from a rural area, I'm also really pleased to see that snake bites are being given the attention that is due, because people who come from rural areas know how important an issue this is, and the real situations that can emerge when the time that is needed, the time that actually is required to access services when the person is not able to get the services on time, the anti-venom services on time, the severity of morbidity that can manifest. And so it's excellent to see this being highlighted. So with that, I'd like to now go on to our next speaker. And this is Betty Ann Bryce, and she's a senior policy analyst at the Organization of Economic Cooperation and Development in the Center for Entrepreneurship, Regions and Cities in the Regional and Rural Unit. She joined the OECD from the US White House Office and National Drug Control Policy, ONPCD, where she served as special advisor for rural affairs, and she's also held different roles at the US Department of Agriculture. Her presentation will focus on access to healthcare in OECD rural regions, with an emphasis on how data is required for improving access. So over to you, Betty Ann, and thank you so much for being with us.
Thank you so much, and good morning and good afternoon to everyone, and hello to all the participants and speakers. Next slide, please. I wanted to just give you briefly set some context for just this quick conversation we're about to have. I work in the rural and regional unit, slightly different than my colleagues, because when we go in, which is the kind of well-being framework that you're looking at on the screen, we try to look at rural communities from different parts, what's taken away from their well-being and what needs to be done from a policy level at the national, regional, and local level. What are the actions that should be taken to kind of help with that? Next slide, please. I wanted to take a quick look because a big part of well-being is healthcare and health services, and that's the context of why I'm with you today. And I know we're talking about health information systems. So before going to the access piece, I wanted to just point out that OECD countries are doing well in the sense that they're improving countrywide the use of national electronic healthcare records. And we see that movement. The most recent OECD work on healthcare information systems reported several countries had moved towards national systems. They've also moved towards one patient, one record. There are a few countries that are working towards that. Where they disaggregate and maybe where they fall apart is, and it goes to something Theodora mentioned earlier, is the type of information that is shared at the national level versus at the subnational level. And then the other types of information that we think is important for rural communities, which is the concern here, that is maybe not being picked up. So we know that health access is unequal across OECD regions. That I'm sure that's not new to you. We have 38 member countries. This network is much wider than that, but I'm sure we are all experiencing the same things. And specifically, health services and doctors is distributed unequally across regions in the OECD countries. And this is a cause for concern. This is a cause for all the issues that we're talking about. Next slide, please. We have a number of residents who are reporting different types of injuries and different types of healthcare challenges. But here, this shows you where it is, you know, who in rural versus cities and the number of health problems that are being reported. And so we're seeing in rural a number of different types of significant health problems in line with what you've heard earlier. Next slide, please. The number of the factors, again, not surprising, that are affecting access to healthcare in OECD countries is, you know, in line with actually what Karin was talking about when she mentioned Burkina Faso and a number of countries that she identified. Workforce supply, and here workforce supply is very sensitive because it's very difficult to attract and keep health workers in rural communities. So for example, think about Australia, the US, think about all the countries that are members. They are struggling with attracting and keeping health-related workforce. Could be community health workers, could be social workers. It is still an enormous challenge. The cost of delivering services is also attached to that, right? Because you can't attract the workers. How else are you going to be delivering these services? Next slide, please. So here I just wanted to illustrate a few of the things. I mean, there is also the affordability of healthcare and the limited availability of it. And we'll go a bit into that more, but these are some issues that are very, very relevant in OECD countries today and was very visible, obviously, during the pandemic. Next slide, please. So just wanted to share with you some factors coming out of our latest work that on average people in rural areas in France, Germany, and the United States have much lower access to hospitals. You know, hospitals are closing, rural hospitals are closing, and that is a big part of how care is delivered in these rural regions. So if you're losing hospitals, where is that healthcare access piece becomes much more of a challenge. And then we talk a lot about digital and technology, but we also know that there are some challenges with that as well. Next slide, please. There's also some factors contributing to the pressure on health systems in general, right? So you want a healthcare system, but what does that look like when you have lower life expectancy? So in addition to all the challenges, you have the substance use crisis that has hit a number of countries, rather have devastated a number of countries. And in rural areas in those countries where you're seeing people who are self-medicating and subsequently dying in larger numbers than in their urban counterparts. And this is relevant because this is a layer that puts additional pressure on communities that are already losing their hospital healthcare infrastructure. And as well, the next slide, please. The aging population, there's a lot of work being done on the aging demography change across the board, or population change across the board. And we're seeing that rural regions are increasingly becoming, seeing elderly populations. And of course, that has a lot to do with the cost of delivering elder care and all the related chronic challenges that elderly population could potentially have. So these elements are putting pressure on the rural healthcare system in addition to all the other factors in the OECD countries. Next slide, please. And so the challenge then is to think about a system, or to deliver a rural, build out a rural healthcare system that is thinking about these pressures and is able to at least manage the other aspects that we've mentioned, and also kind of communicate with each other and deliver the informational systems that is needed. And that is indeed the biggest challenge right now in OECD countries. So I really appreciate, again, the work that was done before, because there are elements of it that that is relevant to all countries. And the issues, again, within OECD countries that come up the most is the quality of care, the access, and the cost, again, not unlike other countries. Next slide, please. And what we wanted really to show you with this slide is that also within that healthcare system, you have the different levels of care, but the different levels of care changes based on where you are in OECD countries, where in rural areas in some of your bigger countries, there is no obstetrician, there is no specialist care. The primary care physician is the person that's delivering everything. And sometimes when you're a jack of all trade, you're not necessarily able to deliver the quality that is needed. And then you have, especially if you need, for example, going back to substance use, we have a mom who's pregnant, who's been using drugs. She's traveling more than 2 hours to the bigger, to the closest city to get the care that she needs, that's much more specialized because of the potential with her child. And this has been an ongoing challenge in a number of the OECD countries. Next slide, please. And here we just kind of try to think about the provisional levels of care that we would be looking to see in the different regions, and how we can maybe bring that closer to rural. And again, I don't want to spend too much time on that, just to illustrate that, again, that is the crux of what we are trying to help our OECD countries move towards. But it is, of course, more challenging because, again, the cost element and the quality element. Next slide, please. So here I just wanted to leave you with a few things, going back to what we said. What we try to do when we work with the countries is we try to give them innovative approaches for sustaining healthcare provision and for kind of working together and talking to each other. So we want them to exploit the networks that are there. We want them to use different models of bringing care into rural communities, whether mobile units, using the technology that is existing, merging where it makes sense to merge, or cohabitating or co-delivering services. And of course, maximizing the use of digital technology to talk to each other, to share across networks, and to build in new data for picking up new, kind of all the other elements around what's affecting care, why people are self-medicating, why people are depressed, mental health and suicides, and those elements that are not necessarily being picked up, but that are a big part of what's happening in rural regions. Next slide, please. And we are thinking more and more about what are those strategies for workforce retention and attraction. And this is really, really important in all our OECD countries, because that's the crux of everything we're doing. It doesn't matter how much improved our healthcare system is or the information systems if we don't have the folks on the ground who can do the work, and how can we repurpose the skill sets that are in communities to help with that access. And then we're looking at that funding and legislation piece, going back to those information systems. What are the data sets what more information do you need? And how can the resources at the national level be repurposed to help get there, as well as the legislation? So this is just in a nutshell some of the things that we are working on. I am happy to follow up with any questions that you may have. Next slide, please. And here's my contact information if you'd like me to follow up, because I know I went pretty quickly. Thank you.
Miriam, that was great. Thank you. I really appreciated your highlighting in particular the importance for resources and legislation to have a strong focus on the data required and the health information systems required to tackle rural health inequities. So it's a great message that you highlighted there. Now I'd like to please go on to our next speaker, who is joining us today from Rural Seeds of Wonca, and her name is Mercy Nafula Wanjala, and she's originally from Kenya, and she's currently Wonca Rural Seeds Ambassador for the Africa region, focusing on advocacy and development of rural health practice among young health professionals and students. And she will present lessons drawn from her experience on the utilization of data from a health information system in a rural health center. So please, over to you, Mercy.
Thank you so much, Susanna. Next slide, please. So I'm going to set some context for you here on where this story begins. And it's where I first worked in rural Kenya in a county called Embu County, somewhere in eastern Kenya. And the particular place that I work, if you look at the right lower corner of your screen, is Mbeere South, which spans almost about 1,000 to 1,500 square kilometers. And I was posted there immediately after my internship to work as the only doctor in that whole sub-county for a while. So next slide, please. So this is the entrance to the health center where I was posted. It's called Kiritiri Health Center, now being upgraded to a sub-county hospital. And when I started off in theory, we had a catchment population of about 25,000. I was the only medical officer working there, with 1 clinical officer and 16 nurses covering the whole hospital, including maternity, the inpatient department, and the CCC department that dealt specifically with TB, HIV, and AIDS. And while we started out, after 3 months of working there, what happened was I realized we were not able to give the services that were necessary, because I noticed that despite us being a health center, we served as a referral center to about 16 other dispensaries and 3 other health centers. So immediately there was a doctor there, they began sending all their patients from the dispensaries and the health center to our health center as a referral center. But since it was a health center, we did not have a theater, we did not have any radiological services. And so there was so much we could not do, and we could not cover the hospital 24/7. Next slide, please. So after 3 months of badgering the then chief officer of health on the fact that we need more healthcare workers, the response that I got from him was, your health center does not have enough traffic for you to demand this many healthcare workers. So I tried to prove my case, and I tried to explain to him how much work we're doing. But at that point, I was still a bit naive, and I did not know the importance of using data, until one person who had worked in the place for a while pointed out that we needed data to convince him. So I asked myself what data, because I knew for the 3 months that I was there, the health records information officer, who was then a student volunteer, was constantly sending data to him. So I asked myself, what data do I need, and what is the data for? Because I was still sending him data, but this data was not telling him what I was trying to say. So I sat down and asked myself, what do we need data for? One, we needed more healthcare workers. We needed to expand our services to cover surgical and radiological services, because the The whole sub-county did not have any referral centers, did not have a center that provided these services. And our location was prime and perfect to provide these services. And one more thing we needed was for the facility to be upgraded to a level 4 so as to serve as a proper referral center, because a level 4 facility would receive more funding and would also receive an expansion of services and also more healthcare workers. So this was the kind of data, this was the data I needed to use, and this is what I needed to use the data for. Next slide, please. So after deciding what I needed the data for, I asked myself, what do I need? What data do I need? So if you look on the left side of the screen, there's a screenshot of what the DHIS looks like when you ask for maybe summary data of either from a facility or national or subnational level. That's what it will give you. But the thing about this kind of presentation I came to realize is most people don't like graphs. They don't like things that they don't understand or they cannot be explained to. And nobody in my team at that moment had the capacity to interpret and explain this data in a way that it made sense and it told the story that we needed to tell. And at the bottom left corner, you can see the graphs that we used to present at the county health meetings as what is happening in our facility, because they told us this is the way that data needs to be reported. We want to know about your ART patients, deliveries, fully immunized, 4th ANC visits. So it was a matter of more of output indicators of health than the process that we were going through to get to that place. So we settled on providing 24-hour hospital reports in the simplest manner possible. We decided we are going to represent the data that is most necessary, but in a simple manner that someone can just look at it and understand. For example, if you look at the first 24-hour hospital report, you'd see that outpatient visit, wow, we had 109 people that day between 8 and 5. And we only had 1 clinical officer and 1 nursing officer working in the outpatient. So you'd see with those numbers and that the 2 staff, you'd see they are actually overwhelmed at some point. So this data was telling a story. Next slide, please. And so as we continued collecting the data, it came to a point that the staff began to ask, why is it that we are collecting extra data apart from that which we are feeding into the DHIS? So I had to explain to them that this data is for us and for the community. And the community, in this sense, we had the healthcare management committee that represented the community interests at the health center. And for them, they also had the same concerns. People are not getting good services. There are very few staff. We're serving as a referral center, but in real sense, we cannot handle most of the cases that are being referred to the facility. So they were also brought into the picture to own the data, to create a sense of ownership. And this actually increased the frequency and also the quality of the data that you were getting from the staff at each point of service in the health center. So the healthcare workers were also on board and they owned the data. The administrator, that was myself, the nursing officer in charge, and the hospital administrator also began to own this data. And most of all, the records information officer, who was a volunteer, but who played a crucial role because we didn't have the computers to collect the data. We didn't have the technology or the applications. So what we used to do is she would go at each point of service, look into the patient records books, do the tallies, give them to me, then I type them on my laptop and send them to the chief office of health. Next slide, please. So finally, it came down to what does the data tell? What story is it that we wanted this data to tell in order for us to improve our services, to improve the health of the community, and also to relieve some of the socioeconomic impacts that came with us having to constantly refer people who have already been referred maybe 30, 40 kilometers away from their home, and then we have to refer them another 40 kilometers again to another place for them to get the services that they needed. First of all, it told the story of we have many patients, few healthcare workers, we need more. And high volume MCH, because we were seeing about 100 patients at the maternal and child healthcare center in a day. And we had very few nurses who were helping with that. We had an active inpatient that needed 24/7 nursing coverage. There was a need for cesarean sections. There was a doctor available, but no theater. And the facility was serving as a referral center, but there is no capacity to serve as one. Next slide, please. So after about 6 months of giving this 24-hour daily reports, what happened? When they hired the next group of healthcare workers, they were able to send us more clinical officers. So we had 6 general clinical officers. That meant we are able to cover the outpatient department 24/7. Because at night and over the weekends, the health center had skeleton healthcare workers, meaning it was almost shut down. So anybody who needed services in that whole sub-county, anyone who needed referral services, who needed to see a doctor, had to travel all the way into Embu town, which was about 23 kilometers away, 40 kilometers or 50 kilometers for some, just to see a doctor. So this really helped with that. And then we received 1 pediatric clinical officer who is the work at the MCH and also improved the quality of services. We received 1 ophthalmology clinical officer, and by the end of those 6 months, we had 23 nursing officers. So we had 7 extra nursing officers sent to the facility. And we had a theater construction project underway. It had been looming in the horizon for a while, but after we started sending the data and proving our case and making a case for it, it was finally begun. And finally, also the radiology department was at planning stages at the 6-month mark. Next slide, please. So this is just a picture of us at the first official site visit for the theater project. It may not look like in the photo, but we were very pleased and very happy, and so was the community. Next slide, please. So this is just a view of the ongoing theater project at that time. Next slide. Yes, so just more photos to show you the work that was underway after sharing and making a case with that data. Next slide, please. So in summary, the principles that I learned from this process, and I think can be applied to many rural and remote areas where you're working with skeleton staff, barely services to cover the population, is 1, keep the collection and collation of data robust but simple. Because you want this data to tell a story of the community that you're serving. You want this data to actually make a case for you, because sometimes the data that goes into DHIS2 is mostly used at national and subnational level to effect policies at that level. But the stories that are happening in rural and remote areas often get lost in that. So it's important that first of all, we collect it, and also we collate it in a way that it is just simple for anyone to understand. And the second important thing is ownership. The community, the healthcare workers have to own that data. A lot of times the community, especially rural communities, are kept out of this. But when they understand what the data is being collected for, how it's going to be used, and when they see the impact that it has in their community, they'll even be more willing to participate and also actually give the data when you go there and say, oh, I need data about how much you're earning, what activities you're doing. They'll actually be more willing to even give you more. And something also very important is contextualization. Work within your context. We have very many apps out there. DHIS is one of them. Today, I've seen 2 more, which are very, I believe will be very instrumental in advancing rural and remote health practice. That's the ACCESSMOD and HEAT. When you're using them, it's important to contextualize, localize them to work for you. What is your community like? What are they doing? What do they need? What are their gaps? So you take it and you contextualize it and localize it into your context. And very important is the analysis. What story does this data tell? Your data should be able to tell a story, not just facts, not just figures. They should be able to tell the story of the community and the people living there and the kind of healthcare services they have and the gaps that they're experiencing. And more importantly, implementation. Data is supposed to be used to bring about change, to bring about progress, to improve on quality, to improve on coverage and services. So the data is supposed to be able to do that for you. If it's not doing that for you, then you need to do something different and make it work for you. And last but not least, most important of all is innovation, because you find that in rural and remote areas, you have very little access to technology. Sometimes there's Wi-Fi and there's a bit of mobile network coverage, but it's very weak or it's very difficult to communicate with it. So what do you do? Next slide, please. I'd like to highlight work that is being done by a local organization called Health Equity here in Kenya, where they're trying various innovative ways to collect data, to harness a lot of data and information from rural and remote areas and use it to bring about change and also policy change. So one of the things they're doing is improving clinical documentation. So for instance, you saw the data that I presented earlier where we had 109 patients being seen by one clinical officer. How are you going to clearly document all that? So they've come up with rubber stamp templates, which are improving documentation. So every time you see a patient, you only need to get the rubber stamp that has what you need, stamp it onto your piece of paper, and then check the necessary boxes. So it's making data collection easier. But now, once you've collected this data, how then do you get it onto a computer, onto a laptop, and integrate it with other systems? So they've come up with an app that actually takes a photo of that, the data on the stamp, and then transfers that data into an electronic medical record in your phone or in your laptop or in your computer. So this has actually been used by community health workers in a very rural and remote region in northern Kenya called Turkana. So these are some of the ways people are trying to innovate in order to make sure that we collect data from rural and remote areas and use it for change and use it to at least close the gap on rural inequities. And next slide, please. So here are two links just to check out what DHIS2 does, because it's a very good platform that really aggregates a lot of data depending on how you customize it for your own local context. And there's a link there for Health Enet. You can see more of the work they're doing and how they're trying to innovate to collect more data and information from rural and remote regions. And there are contacts for Rural Seeds and also for Rural Seeds Africa. In case you need to follow up on anything, have any questions, you can reach me through that. So thank you very much.
Merci, that was just an excellent presentation. Thank you so much. I really, I was inspired by it, and in particular, how you really set out to see the use of the data and how it can influence decision-making, really bringing it to a local level, making sure that, the community was involved and that then the data was acted on, that you had built in the accountability mechanisms with it. Really inspiring. So thank you for that. So I'd like to thank all of the speakers for their very valuable and insightful inputs today. And for some closing remarks, I'd like to now hand over to Bruce Chatter, who is chair, as many of you know, of the Wonca Working Party on Rural Practice. He also is main associate professor and head of the discipline of rural and remote medicine at the University of Queensland. And he's also one of the key co-organizers of this webinar series. So Bruce, over to you, please.
Thanks, Theodora. And I can only say, wow, tonight it's been just a fabulous session. I'm a bit of a, as well as being Professor of Rural and Remote Medicine in Queensland, I live and work in a rural area. I live in a small town. We see lots of snake bites. We see lots of those things that we've heard about tonight at a local level. And I'm a bit of a data nerd, but also a working doctor, and bringing those together is what we've seen tonight. Thanks so much to Ahmed for the big data. I think that was a great way of setting the scene. And then to go on to what Karin could tell us about the actual access that people have in rural areas, the walking time, the travel time, and then the really practical example from Prashant on the snake bite and the real need for people to have access to really good quality emergency care in rural areas. Betty Ann, thanks for the vision for OECD. I think it just shows that this is a universal problem across lower middle income, high income countries. And I think the significant resources sometimes in the OECD can help in lots of ways to assist us in addressing these issues. But thanks so much, particularly to Mercy. Mercy, you showed us that a rural doctor in a small area can make a big difference with the right data, with the justification in those areas to be able to tell the story. I think that's a particular talent that rural doctors, family doctors have in being able to tell their patient stories, but also hear their patient stories and be able to bring those stories to policymakers and to influence change. And you can see right from that big data right down to the local level now how we can affect change in rural areas. And that, I think, is our hope. It's a wonderful partnership between rural Wonca more generally, and WHO in this. I just wanted to summarize by saying I think we've seen what the problem is. The problem is access, it's distance, it's quality of care, its workforce and its facilities. We've seen how we can get a powerful mix of the community, the doctor, and the data to bring a solution that's focused on the needs of rural communities. We often see fragmented care these days. We see vertically siloed programs, we see specialist care. I think the key message from rural Wonca and Wonca is that we have the solution to this. It's not just about doctors, it's about family medicine, if you like. Family medicine is much more than just doctors. In some places it'll be nurses, in some places it'll be community health workers, in some places it'll be doctors. But it's that team, and that might be scattered virtually, it might be scattered geographically, but it's bringing that generalist view to the solution that's really important. We talk about rural generalists. There is an international consensus about generalists now, and generalists need to be able to do family practice, and in the broader sense, they need to be able to do inpatient medicine. They need to be able to do emergency medicine. They need to be able to bring that public health lens to the needs of their communities. I'm hopeful tonight that not only as an older doctor who's been doing that now for over 40 years, but we have a next generation coming along, and Mercy just exemplifies that. We are so proud of our rural seeds who are taking all the data that are so beautifully brought to us by Karin and Prashant, by the others who can help us in our communities to say this is what's important, but not only this is what's important, but there's a solution. That solution is assisted by the technology now of data collection. I think that's great, but we're also now as rural doctors enabled to, we can have some of the greatest centers and greatest minds on our laptops, on our mobile phones to assist our care in rural areas. So I think the days where the rural doctor was stranded with his own knowledge, the stuff that was just between his or her ears, is gone now. And we, as rural doctors who are committed to our communities and are driven by this data, can not only be enabled by that technology, but the technology that can assist us in providing a really good service. We're so proud to be part of Wonca, and thanks, Anna, for coming on tonight to introduce the session tonight. We think that working together like we are, WHO and Wonca and Rural Wonca, and using these solutions, I think we can do great things for our communities. As a professor of rural and remote medicine, I'm trying to push ahead with research in some of these areas. And as I said, tonight's really opened my vision on all of that. And I look forward to working with you all in the future. And thanks so much to Theodora and your team for bringing together such a star-studded cast tonight. We've had a great list of participants on tonight too, and I hope they'll be able to spread the word that we've heard tonight. As I said on the chat, ruralwonca.org will be putting the presentations and the recording up, and we certainly look forward to having some great discussions after all this tonight. So thanks very much, Theodora. I'll just hand back to you for the closing.
Okay, thank you so much. And thank you to all of the speakers. I think it was an excellent overview that was provided by everyone with regards to rural health information system strengthening, and then also really highlighting the contributions of different data sources to this at different levels, and how these can feed into policy making and planning to close coverage gaps for rural communities. So again, thank you very much. Now, the next in the series, the Rural Health Equity Webinar Series, is actually scheduled for the 19th of January. And at that session, we will be looking at qualitative data sources for assessing health services in rural and remote areas, how this qualitative data can be triangulated with quantitative data, and participatory approaches to data interpretation. So I hope that you all can come to that event. Then we also have events scheduled for February in the lead up to International Women's Day. There'll be a focus in particular on rural women and equitable access to health services. And then in March, we'll close the webinar series with our last event on innovations in equity-oriented health service delivery in rural and remote areas in low and middle income countries. So thank you for being part of this this overarching series, and we really appreciate the speakers for their contributions, and also Susana Gomez, who is a key person on the gender equity and rights team in terms of the organization of these webinars. I wanted to just specifically thank her. So now we are set to close. Goodbye, everyone. See you again soon.
Goodbye.
Goodbye. Thank you very much.
Bye-bye. Thanks, everyone.
Bye, everyone.
Thank you very much. Bye.
Bye. Thank you.